will be starting kind of very shortly. What you'll also, I hope, see in the corner of your screen is that we are recording this afternoon's kind of webinar, and it will be available to Sussex Partnership kind of Trust staff kind of on the intranet kind of after this afternoon, but it will only be available internally at the moment. You should be able to adjust your kind of viewing so you can see both the slides on the screen plus the kind of presenters to have that both up at the kind of the same time, but will allow you to kind of to sort that yourselves. The final thing I just wish to kind of sort of to repeat is that please do put kind of comments and questions into the Q&A, and there will be at least 2 opportunities for there to be kind of sort of some sort of discussion around the kind of comments and questions that emerge. Firstly, kind of following Professor Neil Greenberg's talk, there'll be a short time for Q&A at that point. And then towards the end of the webinar, there's a much kind of longer section, kind of after sort of 2 o'clock, where there'll be the opportunity to put kind of questions and comments to all of the people that you kind of see on the slide here, and that you may be able to see on the kind of webcam as well. So it's 1:05, so I'm going to kind of start us off, and it's a real great pleasure to kind of to welcome both kind of Sussex Partnership kind of members of staff and service users, and also from those outside of kind of Sussex Partnership to kind of webinar on kind of moral injury and what we need to know and what we can do about it. And this is been instigated really by Vicky Pattenden, who will kind of speak kind of very shortly from our Veterans Mental Health Transition Intervention and Liaison Service, the TILS service. And we've been kind of very lucky that Professor Neil Greenberg, the Professor of Defence Mental Health from King's College London, so it's Professor of Defence Mental Health rather than he's Professor or he's a Defence Mental Health person, so apologies for that, Neil. But what I'd like to do is actually just to hand over first to our Chief Executive, kind of Sam Allen, just to kind of provide kind of a sort of few words of introduction kind of for this afternoon's webinar. So thank you. Over to you, Sam.
Thanks, Nick, and I'll be relatively brief because I think, like those who've signed up to attend this, haven't necessarily signed up to hear me, they've signed up to hear our fantastic speakers today. And I do want to say a really special thank you to Professor Neil Greenberg for joining us. I feel like we have got the glitterati with us, and Vicky, well done, and kudos to you for securing Neil's time today. And Neil, I think you are having a day off, so you've given your time generously to us. That's a real gift. So thank you. And I was reading a bit about you, Neil. I mean, oh gosh, what haven't you done? But I was totally impressed by your green beret, which was the hard way. I'm sure there were no shortcuts for medical staff within that, and you bring real expertise, wisdom, experience, and I think most importantly, a very strong evidence base to us today. So I'm really looking forward to hearing you, like our colleagues are, but equally from our own colleagues here at Sussex Partnership, our colleagues with lived experience, because for us as an organisation, doing things together really matters to us. And I think equally there's a huge amount of wisdom and experience that sits with those with lived experience. But I should just mention that our Veterans Mental Health Transition Liaison Service has got a particular skill base in dealing with and supporting people who've experienced traumatic events. And of course, as we know, we are still in the midst of dealing with a pandemic, which seems to throw curveballs at us almost every day of the week. Both in the workplace and outside of the workplace as well. We all have families, friends and loved ones, and a life outside of work. And I think it probably would be fair to say that over the last several months, some of us may have absolutely seen family and friends less, Some of us may also have experienced traumatic events associated with a pandemic, and or supporting people who have suffered traumatic events. Just last night, I visited one of our dementia wards over in East Sussex, who have just come through a really tough period, having experienced an outbreak of COVID, the loss of some patients, and also seeing colleagues become ill with COVID. And as an organisation, we have also sadly lost a member of staff to COVID. But some of that sometimes just feels like the tip of the iceberg, because whether or not you're providing care in a clinical setting, whether you're working from home or shielding, we're all living through this pandemic. And I think whilst the vaccine gives us huge hope and optimism for the year ahead, there is no vaccine for mental health. So I think what we need to really lean into is the evidence base, the learning from what we've learned through traumatic incidents over history, not just in healthcare settings, but beyond that. And Nick, you know, one of the things you've really brought to our organisation has been your research and experience, you know, post the 7/7 London bombings. So there is the good news for us is there is a real clear evidence base. There is some really clear and simple things that we can do for ourselves and for each other across our teams and in our organisations and across our health and care systems. And it's not only the NHS workers that are feeling this, it's the care workers, it's everybody in our population. So I'm looking forward to hearing today what some of those more practical things are that I can do for myself and for others, and also to use this evidence base to really build on the work that we're also doing here across the Sussex Health and Care Partnership in terms of looking after our health and care workers. So it's without further ado, I'm going to hand over to the fabulous Vicky Pattenden, who is our clinical nurse specialist in our transition and liaison service for veterans. Thank you.
Lovely, thank you ever so much, Sam. Really appreciate your very kind words, and looking forward to this afternoon's. Again, thank you, Neil, to taking your time out for doing this. I really appreciate it. Same with you know, with my other colleagues from SPFT. I appreciate, you know, taking your time out for today to do this. I just wanted to look sort of discuss really about why are we doing this? Why have we decided to do this, you know, webinar? It was something that came about, as Sam had mentioned, that, you know, within the veteran field, it's something that we had started to come across more within our client group. And it was something that I had been doing some research currently, and realised that how much and how important that malware injury has been a focus currently within the healthcare profession due to the current pandemic. And it was felt that, you know, it would be beneficial to share this within the trust and to ensure that we all think of ourselves whilst caring for our clients. I think that we seem to, you know, we often forget that within ourselves, to, you know, that we are looking after some very vulnerable people, but what about ourselves? So you know, I'm looking forward to hearing some more about the, you know, what Neil's got and the rest of my colleagues. I wanted to just share also that at the end of this webinar today, I will be providing a handout that will have all the information that's being shared today, with some future references for us to take away. So there will be stuff to take away as well, and as Nick had mentioned, it is being recorded. So thank you very much, and again, thank you everyone for taking part today, and I'm going to pass over to the wonderful Professor Neil Greenberg, and the floor is yours now.
Thank you very much indeed. Yeah, I haven't got much to live up to, have I really? Given all those nice acclamations. And the reason actually I went and did get a green beret some time ago is with this haircut, you can get quite cold without a good hat in the winter, so I had to go and get one. So I think I'm going to share my screen, at least I hope I am. So I'm going to press that. You cannot share the screen. Oh, I can share the screen now. Hold on. Great. share some of the evidence base that we have, but also in sort of good science kind of way, I will end up leaving you with some questions rather than just giving you lots of answers. But hopefully there'll be things that you'll find interesting. You've already heard who I am, so I'm not going to go over that, other than to say that at the moment, this is my Twitter handle. So if you like Twitter, do follow me, and I pump my papers out there. But at the moment, I'm quite engaged, actually, obviously, as is Nick, with NHS England and Improvement in trying and help from a sort of national point of view as well. And I can tell you that moral injury is one of the topics that sort of drives the national NHS England and Improvement team, as well as lots of other topics looking at mental health. So moral injury is a topic that first sort of came up from the military. I'm going to show you a little video, which lasts a few minutes in a second, but it's very worth saying, and you obviously know this now, that although the military kind of started this off, this is a topic that actually applies far more widely than military personnel. And at its heart, I'll just give you two definitions here. At its heart, it's being involved in a situation that strongly clashes with your moral code. One thing that's really important to remember about moral injury is a bit like the term burnout, which is a term I don't really like too much. It's not a diagnosis. So it's a really important concept. It's something we absolutely should know about for veterans and for lots of other professions. But at the moment, if you looked in the ICD-10 or 11 or the DSM-5, our diagnostic books, you won't find moral injury in there as a concept. So I'm just going to play you this short video, which hopefully kind of gives you a bit of an overview, and then I'll go through some more detail.
Moral injury. What is it all about? What is moral injury? Moral injury refers to the intense psychological distress which can follow actions or the lack of them, which strongly clash with someone's moral or ethical code. Whilst moral injuries are not mental illnesses, they can cause strong feelings of shame, guilt, or anger. The history of moral injury. Moral injury is not new. It was first written about possibly as far back as the ancient Greeks. Since that time, there is continued evidence of its impact on military personnel up until the end of the Vietnam War in 1975, and of course in subsequent conflicts as well. Moral injury does not just affect the armed forces. Whilst the term moral injury is often linked to military service, it can affect many other occupational groups, including media professionals, social workers, healthcare staff, vets, lawyers, and aid workers, to name but a few. What causes a moral injury? Moral injuries may occur in three ways. Firstly, when an individual or someone else has done something which they should not have done. These are known as acts of commission. Secondly, when an individual or someone else should have done something but they did not. These are known as acts of omission. Thirdly, when an individual feels betrayed by others, often by a higher authority. The spectrum of psychological difficulties. Moral injuries occur along a spectrum. Some people don't seem to be affected much at all. Others experience short-term distress with no substantial lasting impact. However, when the if-onlys and what-ifs do not go away but become more intense, then a moral injury has developed, some of which develop into a formal mental health disorder. What is the impact of moral injury on mental health? Research carried out by King's College London shows that morally injured people are vulnerable to developing other mental health disorders, including PTSD and depression, and experiencing suicidal thoughts. What are the risk factors for moral injury? Certain situations make moral injuries more likely. Events involving vulnerable people, such as children or injured colleagues. People feeling unprepared for the emotional consequences of their role. A lack of social support, or people who experience traumatic and morally challenging situations at the same time. Moral injury acts as a barrier to recovery. Unfortunately, people with moral injuries often feel ashamed, guilty, or angry, which can make them very reluctant to talk about their difficulties with anyone, including clinicians. They may worry what others will think of them or even get in trouble with the law. However, because they don't speak about their experiences, they can't make sense of them, and so they don't get better. Treatment for moral injury-related ill health. Currently, there's no clearly defined way to treat moral injuries. Clinicians therefore find it difficult to provide support to those who experience them. Some psychotherapies may also make moral injuries worse. Currently, the most effective way to provide support or treatment for moral injuries is to help people make sense of what has happened to them. Conclusions. To sum up, moral injury is not new. It's often linked to the military, but affects people from all walks of life. It's not an illness, but it can have a serious impact on people's lives and lead to a range of mental health disorders. If someone has a moral injury, they should be helped to make sense of their experience or be encouraged to seek professional help.
Okay, so that was kind of the brief overview. I could probably just shut up now and just and say you've already heard it, but I was going to run through some of the bits to do with that in a little more detail and add some other bits on as well. Now, it's fair to say that people have often used the term moral injury and PTSD kind of loosely and put them together at times. And I have to say there are some similarities, keeping in mind again that PTSD is a diagnosis and moral injury is not. Some important differences that I think are worth saying is that with moral injury, the predominant emotions that tend to get expressed are those of guilt, anger, or shame. Whereas, certainly in older diagnostic textbooks, the fear, helplessness, and horror was more predominant in PTSD. And PTSD classically is more about safety. I think I'm going to die, something bad's going to happen. Whereas here, what is lost with moral injury is trust. I can't trust that I'm doing the right thing. I can't trust that those around me are doing the right thing, and that I feel let down by people who shouldn't be letting me down. Mentioned in the video is we did this review of looking at occupational moral injury. How does moral injury affect people at work? And as the video said, that the strongest association was with PTSD, but importantly, depression and suicidality are also linked with this situation with moral injury. But it's fair to say that most of the studies at the moment are related to the military. And so if we're looking at moral injury in journalists or in healthcare workers, we have to be just a little bit cautious. We did a study called the Imagine study, where we had both an online questionnaire and some interviews of veterans, but also clinicians, looking at trying to get a more in-depth view of what moral injury was, particularly in military type personnel. And I'm just going to show you some of the data from that, because I think some of the quotes are quite useful. So in terms of the development of moral injury, military personnel are required sometimes to kill others. That is part of their job. But in this particular individual, you can see that this quote kind of says that in their head, this isn't right. Somehow they couldn't square the idea that what they were being asked to do with their own set of personal values. Killing is killing, and actually in war, if you do kill someone, it's not murder because it's legal. That's a legal definition that doesn't always translate at all, I would say, into people who actually have to do those killings. One of the really fascinating things that came out of interviewing a lot of people on this topic was this concept here, which is sort of embodied in this quote, is that actually as people develop moral distress, so that kind of early stage, if you remember the spectrum piece, before they develop moral injury, they kind of become distressed and they kind of think about it, or they try not to think about it, and it just doesn't make any sense. They become injured, and then a pathway that may happen, often portrayed by the media, is that they may end up, with PTSD or taking their own lives or some terrible outcome. And actually what this quote says is actually many people do kind of get stuck in this thinking about the morally injurious event, and then they kind of just decide they've had enough. That's not where I'm going, that's not me. And they almost do something that we often advise patients not to do, which is they put it in a box. They look it up and they put it to one side and they say, that's just one of those things that happens, and they move on. And actually, a lot of these people seem to have done this well. They seem to have moved on as an active decision that they no longer want to be morally injured, which is kind of a funny concept, because it's not what we in clinical sort of settings tend to do. We tend to try and understand the meaning behind it, but we'll come back to that a bit. The sort of as I've got all those pieces. Another thing that came out as well is about this concept of post-traumatic growth that many of you may have heard of. And that's this idea from as far back as Nietzsche, which is anything that doesn't kill you makes you stronger. And we found lots of evidence that actually people having struggled with these ethical dilemmas actually came to some sort of realization that they felt had actually enhanced their lives. Not that they wanted to be morally distressed or morally injured in the first place, but actually that they took something good away. And then there was this interesting concept between the military and religion and what the military do. And I like this phrase that you may well have heard, is there's no such thing as an atheist in the trenches. You know, that when you're put in these situations where there is no right or wrong answer, and you're put in situations where you and your colleagues may experience some really bad things, actually sometimes religion actually plays an important role. And we wrote a paper many years ago actually looking at the roles of military chaplains on mental health of service personnel. And actually what we found looking historically at this topic was actually the chaplains who tended to be the most effective from the troops' point of view in terms of their mental health were ones who tried to use spirituality and religion as guiding principles for what the military was being asked to do. So one of them was called Woodbine Willie, which I don't know if you've ever heard about. And Woodbine Willie was a First World War chaplain who Woodbines were cigarettes, and he would get around the troops a lot by giving out cigarettes and talking to them, which obviously we wouldn't do these days. But back then he was seen to be a very successful chaplain who helped a lot of people because he didn't spend a long time talking about God. He spent a long time talking about the principles of spirituality and the fact that there is no right answer. Another thing that sometimes happens though is when you do have a strong set of beliefs and then you're confronted by these situations that just make no sense, that tended to sort of lead to a deterioration in people's religiosity, so to speak. And they became less religious because they couldn't reconcile again what they're seeing and what's happening with the situation that they got put in. We found very clearly that there was definitely a link between being morally injured rather than unwell and family functioning. Many people would come home and say, I couldn't interact with my children again because what I've seen and what I had to do. And these children, what would they think of me if they knew what I had done when I was out there? They would think I'm a monster. They would not think that I'm the nice, caring, loving father or mother that they think I am now. We also showed an impact on occupational functioning. And again, this comes down to sort of moral injury, whilst it's not an illness, definitely having symptoms and functional impairment as a result of people suffering with it. One of the things touched on in the video, which I think is important for clinicians who might be listening, is to think about the treatment challenges that moral injury poses. So as we said, the predominant emotions that people feel are anger, shame, and guilt. And what happens, therefore, is if someone goes into therapy because they're unwell, let's say they've got PTSD, post-traumatic stress disorder, they often end up talking a lot about the horror and the terror and the fear elements of that. And actually, they don't want to talk about the shame and the guilt and anger bits because they're really afraid that actually people will judge them, even the therapist will judge them. And we know from studies of military personnel that actually they tend to benefit less from PTSD treatments than non-military veterans. And part of the reason for that might well be is this moral injury piece may never actually get addressed in therapy. They may deal with the fear-based elements rather well. And actually, unless a clinician makes an active effort to seek out the core beliefs underneath of what this made the person think of themselves and the shame and the guilt, it may never get addressed. And that may well end up leaving them, slightly improved, but not really much better. And they don't feel they can talk about the shame and the guilt elements. Another really important aspect of moral injuries, particularly with the military, but also I think will become more evident with healthcare professionals from COVID, is this element of sort of governance and the law and professional bodies. So I'm a healthcare professional. I was working in intensive care, and I think I administered the wrong drug, and a patient died. That patient was really ill. It's my fault. I'm wrong. I can't get this out of my head. I become unwell. Now, the only way that I can get treatment if I go and speak to it is to admit that I've made this terrible mistake and potentially lose my professional registration. Or in the military sense, I may have killed someone, and I think I did it wrong. I shouldn't have done it. I killed them because I was angry, not because they were a threat to me. And again, the only way I can get treatment is to speak to a clinician who then is legally required to report that if you're aware, there is SO15 in Metropolitan Police have a war crimes helpline. So you can phone them up as a clinician to report Nick Gray as being a terrible, monster who killed lots of people in the war. But see, that is something that we have to do as clinicians. We have to report serious crimes. So here you are, you're speaking to someone and they're telling you this stuff. And the question is, do you immediately say, stop, I've now got to go and report this to the GMC or to the SO15? And the answer is, we're not suggesting for a moment that you should do that. What we're suggesting is actually you need to think this through clearly. And importantly, you need to make sure that your client or your patient absolutely understands the impact of what they might tell you. Now, it's interesting internationally here, because if you happen to be in the US and you work in the Veterans Administration delivering treatment, actually, as long as there is no current risk posed by that individual, you do not have to report even the most horrific of war crimes. But in the UK, we absolutely do. So when a patient tells me that, I've had this story, I shot one of my colleagues to shut them up because I thought we were all going to die. Then the question comes is, did they do that, or did they think they did it? And this is the slightly difficult topic, because we know that PTSD distorts perceptions. That's in the diagnostic criteria. So someone's perception of what happened may well not be the reality of what happened. And of course, you as the clinician are not judge, jury, and executioner. Your job's not to try and tease out the legal truth. You're there to treat the patient. So we produced this paper, and I think that the summing point of this paper is really be clear with people that if they tell you certain things, you may have to disclose. And they can often talk about it in ways that don't lead you into that situation. And also, if you are going to think about disclosing, unless there is some immediate risk, speak to someone senior and someone who you trust. Talk it through before deciding to give a disclosure. And this can impact also on clinician well-being, because actually feeling put in these situations can be really difficult for the people who have to sort of make these decisions as well. And we certainly think, and we're actually doing some work with NHS England, the veterans team there, to try and come up with a guideline, at least an algorithm of how to think this through and what you might do. And we've got a legal opinion there as well, because you can imagine, we're not telling people not to disclose stuff they have to disclose, but there is a careful balance here. One thing we don't have with moral injury at the moment is a comprehensive screening tool. There certainly are tools out there to measure events. There's tools out there to measure reactions, tools out there to measure vulnerability, but it's often lots of different tools. So we put together this thing called the MORIS, the Moral Injury Scale, which is at early stage, and we're going to try and validate, because it's a bit too long at the moment, and we need to get it into something that is usable. And we're just now starting on a piece of work funded by the Forces in Mind Trust, kindly, to try and develop a sort of algorithm or a treatment protocol for moral injury. And hopefully later on, we would then want to test it. So we're just doing some interviews at the moment, and we're working towards that. And it's a multi-stage study. But we think it's really important that clinicians at least feel that if they identify moral injury, rather than using a bit of this and using a bit of that, which is what they do at the moment, that there is some sort of process and policy that would be helpful. And of course, as I've said already, this is not just about the military. Absolutely, at the moment, there are lots of professionals, not just healthcare professionals, social care is another good example, who have been put in these really ethically challenging situations. Do I provide treatment for someone but put myself at risk, and my elderly mother or my kids? Do I wait and put my PPE on, which obviously we should do, but what happens when the patient's having a fit on the floor? What is the right ethical thing to do there? And of course, I don't have the answers to that. So we've got a big study called NHS Check, which is going on at the moment. That's got about 20,000 healthcare workers across the NHS, or across 18 trusts. And what we are using in that is a scale that measures moral injury events, the MIES moral injury event scale. And what we did is we split the scale into tertiles, into threes, so low, medium, and high exposure to moral injuries. And you can see here we've measured some different types of mental health difficulties here. We've got common mental disorders, we've got anxiety, depression, and this is a PTSD scale. And you can see it's only really people who are highly exposed to morally injurious events that seem to have a particular increase. It doesn't go up gradually as there. We need to look into this in more detail, and we are. But here PTSD particularly comes up as being doubled almost in people who have high exposure. So we're pretty clear that this is a concept, is something that's highly relevant to healthcare professionals as well. What to do about it, just very quickly, we think that the two things that are useful to do about it is to make sure supervisors can have a conversation about it with people, and also to have reflective practice sessions. So we've been training in the NHS, we've been doing these active listening skills training courses called REACT, which is just an hour of remotely delivered active listening skills. We've done a small pilot here. So this is looking at the confident supporters. So before the training, over half of the supervisors who did this didn't feel confident to support people. 1 month after having the training, 85% felt confident, which is not bad, I think, for a 1 hour intervention. Another thing we think is important is reflective practice. You've probably heard of Schwartz rounds, but this is an opportunity to share your story and to make sure that you can develop what we call a meaningful narrative. So a story that doesn't end up with you being to blame or your boss being to blame, but ends up with the situation being difficult and we all tried our best. So my conclusions overall is that moral injury is not new. It's not only about the military. It's not a mental illness, but it does make mental health problems more likely. It can certainly lead to behavior changes, and that might lead to legal issues. It might lead to accidents and poor quality care and so forth, as well as problems in your home life. We think that it can be diffused, so to speak, by discussion and creating a narrative. This certainly needs more evaluation. We're definitely not saying this is definitely the answer, but we think it is. And we need to get better treatments for it as well. That's me. Thank you very much indeed for listening. I'm happy to take a couple of questions if there's time.
Absolutely. Thank you, Neil. Thank you so much for the run through. And just so that you're aware, there were already a couple of requests for the link to the video, which we actually put in the chat already to the kind of the YouTube page. There are a couple of questions, and if there are additional ones that people want to add, please put them in the Q&A. That will be the easier way to kind of manage them. First question, just want to check it, is from Claire, saying that if moral injury isn't a diagnosis and not in and of itself an illness, how do you kind of help explain its existence to patients, and how do you help them make sense of it?
Absolutely, it's a great question. I would explain it in terms of a vulnerability factor. So we often speak to patients about being vulnerable for various reasons. You've got a lot of stress in your life. You might have had a difficult background, whatever you might discuss. If you're in a situation where you are morally injured and you're struggling with these ethical issues that have happened because of an event, I would lead to, we need to deal with it because we don't want you to become ill and develop PTSD or depression or suicidality, depending on your conversation. So I would talk about it as a vulnerability factor, which is addressable, that we can do something about it, which is why you want to sort of look at it.
Fab. This may be a quick question. We've got two further questions. One's quick, one maybe not so quick. The quick one is, any gender differences in any of the studies?
So the truthful answer at the moment is yes, there are. So it appears that actually men may be more susceptible, but the fact is most of the studies have been done on military males. So we don't really have great data to base that view on.
Fab. And then there's a question from Natalie, who I know from an organisation called Integrate Mental Health, who actually work with kind of mental health providers who themselves have mental health difficulties. And one of the things she's asking is saying it's sometimes difficult for such kind of staff because they may have poor responses from occupational health or management or HR, and that sometimes the system says we're going to be compassionate, certainly to those people who are using services, but are they really able to do the same to their own workforce? And sometimes this can lead to sort of internalized stigma and extra suffering for the professional, so for the kind of like the staff member. And I guess one of the things that kind of that Natalie's asking then is that she says that to her and her organisation, it feels like a type of moral injury because of the context of the work that we do as health professionals, because the system knows better, practitioners know better, but that these practitioners who are having the mental health difficulties are then feeling abandoned. And she would be interested in your view whether this is kind of moral injury, similar to moral injury, how do these ideas overlap?
So certainly one of the ways that moral injuries can develop is through feeling betrayed, often by a higher authority, which would be the system, your boss, your colleagues who should know better, or the NHS as a whole. So absolutely, it could be a moral injury. It could also be, moral distress, and it could also just be really unchallenging and not very nice and not an illness or distress or anything at all. it really depends on what impact that has on you. I absolutely hear that sort of description many times, you know, within the NHS, and I would say within most other organisations as well. It's not restricted just to the NHS. It's important to say. I think the real thing here is to try and slowly, probably, but as fast as we can, engender that culture of actually trusting others. That we are all in it together. Which I do really believe, because if we're not, what are we all in it for? But you know, that's too philosophical to answer, to talk about here. So the short answer is yes, it can be a moral injury, and I think that actually supervisors and managers, you know, and senior executives have to work really hard to foster an environment in which there's trusting, and actually the people who are feeling these strong emotions also need to do a bit of acceptance that actually seniors can't change everything overnight either. That whole PPE piece at the beginning of COVID, you know, if there was not enough PPE, there was not enough PPE. That's not right, I agree, but people can't just magic things up. So I think there's a bit of a two-way, and as Michael West will describe it, you know, if we can get more compassion and more kindness within the workplace, I think everyone will benefit from that.
Thank you, Neil. And just to kind of to add that there was a comment from Sam Allen, kind of answering that, kind of saying that certainly within Sussex Partnership, lived experience, really we want to see that, and we do see it as a strength, and that as a trust there's now a lived experience network and neurodivergent network which are starting to kind of to help us kind of with this process as well. So just to flag that up and to remind people of that, that's for sure. Great. So Neil, it just leaves me to say kind of thank you so much for joining us. We'll kind of look forward to kind of following the kind of as the evidence kind of progresses, as the kind of the treatments kind of sort of progress as well, and as a group we'll be kind of continuing to kind of work with these ideas and discussing these with the people in the webinar about, you know, what do we do now as well, because I think there's lots more for us to discuss. But just to say thank you again for joining us, and it's my pleasure actually to kind of hand over now to kind of two colleagues working in the TILS service, Anita Young and Catherine Campbell, who have themselves, of course, been working with people with kind of moral injury, and their talk is around kind of an exploration of that work and bringing in these kind of concepts. So I'm going to hand over to Anita and to Catherine.
Great, thanks, Nick. So just to introduce ourselves first, my name's Anita Young. I'm one of the psychological therapists with the Complex Treatment Service, and this is my colleague Catherine.
Hello, I'm Catherine Campbell. I'm one of the clinical psychologists with the team.
As Nick said, our part of the presentation is an exploration of working with moral injury in service users. We're going to split our presentation into three parts. So measuring moral injury, the clinical assessment, and treatments in development. There'll be a slight military angle to our presentation because we do primarily work with veterans, but we do think a lot of what we'll present today is easily transferable into working with the general population. So moving on to thinking what might put your radar up. What might you hear or see in your clinical room that might make you think that this person has either been involved in a morally injurious event or may have moral injury? So again, just reiterating what Neil has talked about, you're really trying to listen out for those feelings of guilt, shame, anger or disgust, rather than maybe the fear-based emotions. Really consider what they're telling you about the situation that they've been involved in. Were they involved in a combination of high levels of responsibility and low levels of control? Think about the context. So maybe it's a member of staff working in the NHS. What ward and what unit were they on? Were they working in intensive care? Were they on a rehab ward? Were they on actually a COVID ward? And if they're a veteran, consider what combat they've been out on and what operations they've been amongst. And then really tune into what they're saying to you. There might be some subtleties that you start to pick up on. So it may be that they say things like, I've not been able to talk about this to anybody before. So this could be them priming you that there may be a disclosure. So Neil has talked about disclosures and some of the boundaries around that. So you may want to kind of refer to that paper and think about how, if you think that's going to happen, how you're going to manage that. And then the other thing which is really important is how you handle it. So they may say things like, there are things which I'm not ready to talk about, things I'm not comfortable with, or things I've done. So this could be them testing you a little bit. So A, do they think that you can take it? Or B, are you going to respond in a manner which reinforces their guilty or shameful feelings? So the message you need to kind of give there is quite reassuring, that you're within the boundaries of disclosure, that you're ready when they're ready. So that tries to attend to, rather than just them being able to talk about the fear-based stuff, opening up that conversation for the more guilty and shameful feelings. Next slide. So measuring moral injury. So this is a tricky one. So if you do a search, you'll see that there's lots of questionnaires out there for moral injury, which Neil has alluded to. All of them have a slightly different angle on them. And my understanding is that's why Victoria Williamson and the team at the King's Centre for Military Health Research are developing this Morris scale, which tries to pull all the qualities together from the scales that are out there and come up with a gold standard questionnaire. So that's currently being validated, and I guess we keep our eyes and ears open for that. But just to give you a little flavour of some of the questionnaires out there, the first one to talk about is the Moral Injury Questionnaire military version. That's the one we actually talk about, we use in our service. Its main idea is to capture as many psychological, ethical and spiritual challenges that the people may have been involved in. And again, just to give you a flavour of some of those questions. So I did things in war that betrayed my personal values. I feel guilt for surviving when others didn't. Seeing so much death has changed me. The next questionnaire is the Moral Injury Event Scale, which seems to be the one that Neil's just been talking about in his research project. So this is a 9-question self-report scale where people rate either 1 strongly agree to 6 strongly disagree. And again, just to give you a flavour of this, I saw things which were morally wrong. I acted in ways that violated my own moral code or values. I felt betrayed by leaders who I once trusted. So Catherine and I have talked quite a lot about the use of questionnaires, and also with one of our colleagues over in the Wales CTS team. And we think, yes, it's good to get numbers because you can track people's recovery, but also it's such, you can get such rich clinical information from using a questionnaire, and you can use it in kind of not just a tick box numbers gathering way. So thinking about asking, presenting it, it has a focal point for your conversation. So if there's feelings of guilt and shame, you can begin to open those conversations really gently with the questionnaire. It also gives a clear message to the patient or the person you're working with. There's a questionnaire developed here, so I'm not on my own with this. And also some of the questions may be so familiar to them that it immediately starts to kind of reduce some of that shame, because other people are thinking and feeling the same things as them. So you've got your antenna up, you're thinking there may be some moral injury here, you've considered using a tool in one way or another. And then if I hand over to Catherine, she's going to really talk a little bit more about the clinical assessment and things for you to look out for there.
Thanks, Anita. So really just the top of the slide's a definition of morals. So fundamental assumptions about how things should work and how one should behave in the world. So it might make sense that to receive a moral injury that you would have had strong morals to begin with. So in the clinical assessment, you might want to get a sense of who the person was prior to the incident, so their pre-existing beliefs. If you already work within a CBT framework, the Ehlers and Clark PTSD model identifies the importance of eliciting prior beliefs to help aid conceptualization. So this might be something you're already doing. And so what they suggest is that the vulnerability may present when faced with a situation which either conflicts with or shatters these beliefs. So again, the assessment is looking to identify what this situation is and what it was about it that was so distressing for them. So, for example, if you've identified that someone's got a strong sense of right from wrong, they've joined the military, and then difficulties have arisen when they've been faced with the reality of war. So your assessment might have identified that they've been involved in the more recent military conflicts, so let's say Iraq, Afghanistan, and these are seen to be more unconventional. So for example, someone might have come across an incident with a child soldier. So with this situation, it might have been harder to stick to or to follow protocol, so setting up that vulnerability. So the reality of war or the reality of working with COVID might not fit neatly with how people have been trained and what they've rehearsed. And this can set people up for the cognitive dissonance and also that vulnerability to maybe developing moral injury later down the line. And as we've already mentioned with the clinical work, the importance of the therapeutic relationship, with shame being so present, you know, the stronger the relationship, the more likely it is to facilitate disclosure. Thank you. Next slide. So really just a list of some of the questions you might want to ask in your assessment. Neil's touched on a number of these as well. So the pre-existing beliefs, Anita mentioned about the context, how prepared people felt, the decisions they were involved in, and just the getting the appraisals and the associated feelings. So how have people made sense of it? And what are the distressing feelings that have come with that? There might also have been a change in the meaning of their experiences. So for example, somebody within the military is able to make sense of what happened when they're still in the military and they're surrounded by people with shared experiences. But actually the problems have arisen when they've transitioned out into civilian life, where there's a different set of rules that we live by. And again, just looking at support systems people have felt that they've had in place, what the leadership has been like. So have they felt supported, or have they felt let down or betrayed? And again, as Neil mentioned, you know, just exploring any religious or spiritual beliefs and how this has influenced things. Have they found that quite comforting, or have that sort of fed into, you know, whether or not they might be punished by God for some of their actions in combat, for example?
Thank you, Catherine. So we've covered a bit about possible ideas for measuring moral injury, and then Catherine's just given us some really good hints and tips around the clinical assessment. So moving on to the third and final part of our presentation, which is ideas for therapy. So as Neil has already mentioned, currently there's no clearly defined way to treat moral injury, as it's not a diagnosis. It's a set of meanings that lead to those feelings which we've been talking about: guilt, shame, anger and disgust. So if you had a patient in front of you with a clear PTSD diagnosis, you'd know where to go for your treatment. So you'd either fall back on trauma-focused CBT, EMDR, or possibly cognitive processing therapy. With moral injury, that's slightly more tricky. So it could be a very short presentation, but we are going to talk about some ideas out there. So the good news story is, as you've seen, there are feasibility studies going on for the King's Centre for Military Health Research, but also over the last few years, there have been a number of programmes which are running and operating out there. So we just wanted to give you a little flavour of what these might be and see if they're of any interest to you, to dig into them a little bit more for yourselves. Also, to kind of reassure you, the people that don't work with veterans, the themes that run throughout all of these are really common in your clinical practice. So compassion, working with self-forgiveness, shame, moving towards value-based living. So the first one to talk about is called adaptive disclosure. So they title this adaptive disclosure to move away from any stigma that may come from the words therapy or treatment. And it was specifically designed to treat active duty service members and veterans, so people out on operation as well as people that have left the military. It really promotes coming to terms with the meaning and the implication of three core types of traumatic war experience. So life threat, loss and moral injury. Again, all of those we would see in our general population patients. It is a hybrid of cognitive behaviour strategies and techniques drawn from Gestalt, psychodynamic therapy and mindfulness. The second of the four to mention is the impact of killing treatment programme. So obviously this is slightly more military focused, but some of us during our clinical careers will unfortunately see people that may have been involved in someone's death. This programme was specifically developed to bridge any gaps that are in traditional PTSD treatments, and is designed as a bit of a bolt-on for the evidence-based psychotherapists for PTSD. It involves lots of self-acceptance and self-compassion, and involves a certain amount of compassionate letter writing. Its key themes are around acceptance, self-forgiveness, reconnecting with spirituality or humanity in a meaningful way. The third of the fourth is acceptance and commitment therapy. So again, the clinicians out there will all have heard of this, and most of you will be using maybe some of the principles of this. So there's a really lovely paper by Farnsworth in 2017, which we do have a reference for, which looks at a clear rationale of how ACT and moral injury are a really good fit. So he quotes Haynes saying that ACT is an evidence-based behavioural intervention designed to address a broad range of clinical concerns, symptoms and diagnosis, and focuses primarily on increasing behavioural and social functioning. In that paper, they really talk about how therapists using ACT in moral injury can try and refocus their clients to making value-based life choices rather than surrendering to value-based living, trying to really move away from those really self-critical thoughts of I'm a monster or I'm bad. And ultimately, the end aim is for the clients to be far more compassionate for themselves and view themselves as whole rather than maybe defined by one moment in time.
Thank you. And the fourth of those is called the trauma-informed guilt and shame reduction. And again, this is based on CBT principles and acceptance-based principles as well. A lot of this would be very familiar to you already working clinically. So just some psychoeducation around the function of guilt. They propose a model of non-adaptive guilt. So that sort of says that if guilt's avoided, it can set up a vicious cycle of shame and distress instead of being appraised and used adaptively. So the module 2 looks at appraisal, so where the source of the guilt and the shame has come from, and again uses techniques that you might already be using: responsibility analysis, justification analysis, and then the last module is more moral and value based. So this is just a reminder of what Neil was talking about. So this is research undergoing currently. So this will be really exciting when this comes out. So just to keep an eye out for that. So really, when should we hold moral injury in mind? So when emotions aren't fear-based, so when shame and guilt might be present. As Anita took us through, there's some tools that can facilitate conversations. We can use the assessment to gain a bit more context around the situations they've been involved in, and that can build up your case conceptualization. But also remembering that a lot of these skills you may already have and be using. So those to work with guilt and shame, using compassion focused work, and also encouraging bold steps towards a value-led life. And with all of the clinical work already, just using supervision to manage any difficult material or difficult disclosures, or just gaining advice, as Neil mentioned as well. And then the final 2 slides are just references and then some resources. Thank you.
Fabulous. Thank you, Catherine. Thank you, Anita. Just to remind people that all of the materials, the slides, references, links to videos will be kind of made available to everybody after the webinar. And what we're going to do is we're going to take any kind of questions and comments for the particular presentations together at the end after the next 2 presentations. The next presentation, it's a great pleasure to introduce Louise Patmore, who's the patient lead for Sussex Partnership, amongst many other hats which you can introduce if you wish, Louise. So I'll hand over to you. Thanks, Louise.
Thank you. Yeah, so a little bit out of date. I'm the participation programme lead for our healthcare partnership across Sussex. Very much today, I think I'm going to talk from my own experience, which I don't use that often. But what I don't want to do is represent moral injury in saying I'm representative of the service user voice across Sussex, because I'm definitely not that. Over the last couple of weeks, I've been really sort of looking at this concept from my perspective and the way that I've been in and out of services and sort of my life story, I suppose. And it's one of the biggest sort of questions that I've really struggled with in a way. And I think even now I'm sort of being enlightened by the idea of the safety versus trust and all those other kind of things that we've been talking about just now. And I've been taking some notes down. And I think from a service user perspective around how clinicians are being looked after and what they understand and know of people that are coming into their services really helps look after each other, because I think compassionate leadership has been something that's been I've been championing since I was staff governor in 2016 and still currently. One of the reasons why I took that on was because I realised that actually if people can't look after themselves in the work environment, how are they supposed to look after somebody as complex as me? And some people that are in this conversation have indeed looked after me over the last few years. And without them, I wouldn't be able to sort of talk sort of eloquently and calmly today. But certainly my life has been littered with anger, shame, guilt, and betrayal. And the one thing that I've sort of drawn out really is about skewed morals and self-perception and perception of others around me. And some of that perception is around some of the clinical interface that I've experienced. I've had many clinical engagements over the last sort of, well, most of my life really, from sort of childhood, but on and off, and in more recent times over the last 20 years. And I've had some amazing therapies and I've had amazing support, and people have gone extra miles the whole time and consistently with me. And there's been one or two events that haven't gone very well. And I think the reasons why they didn't go very well was because people weren't looking behind the behaviour. They were looking at me in terms of my presentation of, just going to show you something now, of I'm fine, thanks. I don't know whether you're going to better see that, but it's a sort of comedy thing about the British emotional will that says, you know, how are you doing today? I'm fine, thanks. What's sitting behind that I'm fine, thanks is quite often a story that is so overwhelmingly complicated, especially when you're talking about childhood sex abuse, childhood emotional abuse, which creates a difficulty of description you can't even begin to describe when you sit in front of somebody and you say, how can I help you, what's wrong? And you can be quite dismissive, glib. I've got sort of boarding school syndrome, so you won't see me when I go into fear mode. You won't necessarily see that occur, it just happens. So being able to make meaning of that in a sort of safe place and be able to explore my own sense of injustices that I've put onto people and difficulties that I've done and put myself in and been unreasonable and other things where I'm trying to seek my own meaning from my own life. Spending a lot of time with perfectionism. Some people might recognise that as a problem of mine. Black and white thinking and those types of things. How do I do things? And if you've got to move away from people or lean into people in different ways, and how has that been perceived by people? And so I have my own anger, shame and guilt about what I've done, and sometimes that becomes an expression to other people. And over the years, I very much delayed. In my 20s, I absolutely delayed the support that I needed. In my teenage years, in my early adult life, I absolutely delayed support seeking because I felt I was to blame for all the things that happened. And being somebody on the receiving end of sex abuse and physical abuse and emotional abuse over a number of years, which I didn't even recognise that was abuse because I had nothing to measure it against, there's an overwhelming conversation in my mind that helps feed rumination, sleepless nights, and all of those things that I can't really begin to unpick. And if I'm put into a clinical environment where it's not acceptable to talk about that or think about that or extend a curious, safe way of hearing that, then that's going to delay my progression through clinical improvement and recovery. And also, I was also noticing a thing about disclosure that came up earlier on, and it just reminded me of something happened a few years ago where I was interrupted from sort of mid-story around disclosure. And if I continued with what I was about to say, that this might end up in justice system. And that was a big problem for me, in terms of I needed to halt what I was saying in case it stepped over the wrong mark. And then I wasn't able to explore that anymore because that completely shut down the entire process of disclosure with that individual. And that was a problem. So I work with Recovery College and a number of other things. I also am in the amazing company of lots of peer support workers and other people. And there was a question earlier on about peer support workers. And so I'm very much in the solution focus these days. I used to be in the problem focus and everything going wrong and catastrophizing and couldn't really make sense of my life through this veil of moral self-perception and that stuff. The compassion and kindness can't be said enough. The flexibility and the way that we listen to people and each other cannot be said enough. And sort of listening to a story and not discounting it as this couldn't possibly have happened. And then not reinforcing ideas of moral injury by blaming and continuing to dismiss some sort of things that clients might be sort of telling you, because whatever people are saying to you, they're trying to communicate something. And when we were looking at the memories and distorted perceptions and how we put them back into place, we need to be listening to things so that we're able to put things into place properly without judgment. And that doesn't mean to say whether we're going to say things are right or wrong. It's about listening without judgment, compassion, kindness, and listening and not discounting. I shall stop there.
Thank you, Louise. I just want to say there are a number of comments that have come into the chat, and I won't say who's kind of saying, just in case you haven't seen them, just thanking you for sharing your story and really kind of focusing on the kind of compassion, which is helpful to people and really helps people move on. So was already some immediate acknowledgement of the power of what you're talking about. So thank you again for that. And thank you for putting those kind of comments kind of privately into the chat, those of you who did so. If it's okay, I'm going to then move on to our final kind of talk of today. And again, during this, please do put additional kind of questions or comments for any of the kind of presenters into the kind of the Q&A for the discussion part afterwards. For the final talk today, it's a great pleasure to introduce Sophie Holmes, who's the Deputy Director of Psychology and Psychological Therapies in Sussex Partnership. And she'll be talking about Sussex Partnership's Ethical Decision-Making Committee and how this may kind of overlap with the concepts that we've been discussing. So thank you, Sophie, and pass over to you.
Thank you, Nick. And I think I just want to say thank you to Louise, because you've helped me enormously by putting forward that sort of central idea about compassionate kindness, which I think is really at the heart of why we need to be thinking about how we support staff with difficult decisions that they're making. So that's quite a nice sort of introduction into what actually the next part of the presentations is about. So Louise will know this, but I think it's just a really important thing to keep reminding us all about the real value about looking after each other and being kind and compassionate in some extraordinarily difficult circumstances. So we started thinking about how we would go about supporting staff. In the early days, as many of you will remember, we were seeing stories on the news of the difficulties staff were facing in Italy, in particular with the overwhelmed hospital provision. We were really quite apprehensive in those days about how this was going to end up being for our staff and what it was going to be like for us locally. And of course, we look back now and it's with quite a different attitude, I think. We're looking at the second wave, because during those early weeks, we really didn't know what was coming, and we didn't know how difficult this was going to be, or how much we might have some very challenging decisions to make. So we were asked, this was very much an ask from central government. We were asked to set up or to start incident management planning early March. And then as part of that, to set up a clinical and professional advisory group. So that was the first sort of structure that we put in place to be thinking about, as part of our incident management, we needed to have a senior group of professional leads and clinical leads to support with difficult decision making. In those early days, we were working at breakneck speed, and I think it's quite an incredible feat of the organisation that we managed to set that up within about a week or two, and that group was meeting initially weekly and then twice weekly. And it was a very nimble process, which was led, I must say, by Claire Woolcock, who was incredibly helpful as our medical director in steering us through those early days and weeks. So we set up the group with that idea in mind that we would be making or supporting staff with difficult decisions. But then fairly quickly, the Royal College of Physicians published some guidance, which wasn't possibly that surprising, but was really clearly marking a line in the sand about what actually we need to be doing in order to ensure healthcare staff are going to be well supported through difficult decision making. And at that time, I think the Royal Colleges were coming at this from a point of view of what it was like working in ITU. So I think in some ways, as mental health and learning disability staff, this whole landscape was possibly a bit more familiar to us. We're possibly a bit more used to working in a multidisciplinary way and supporting each other with difficult decisions. But it was really helpful for them to set out some basic principles, which I think for many of us in mental health and learning disability, we were kind of quite gratified to see this is what we've already been working towards, with structures in place that lots of you are familiar with, like risk panel or complex care panels, which we already have set up on the basis of, we know that good teamwork and mutual support is essential when we're making difficult decisions. And we are all making difficult clinical decisions all the time. That is the nature of working with people with complex mental health difficulties, learning disability, forensic services. There are an enormous amount of challenging and difficult decisions. And I thought it was quite an interesting observation about what our staff come into the work to do is to care. How then that feels when you're actually put into positions where you don't feel you can behave in the caring way you would want to. And that kind of dilemma for us as healthcare staff or social and healthcare staff is actually what we're wanting to do, is look after people. And that's not always, in our own personal view, possible. We may not be able to give as much care or as much treatment. So it's already very much part of our work. But I guess what was happening in March was that idea that this would veer into the realm of physical health decisions, and about how we would be making decisions about transferring patients into acute hospitals and what we would do if we ran out of capacity. So the Royal College guidance was very clear about the importance of decision-making processes needing to have accountability, inclusivity, and thinking about holding in mind the views of sort of people that we're working for and with. So this is about keeping in mind people's own, say, clients and families' views about what might be best for the person, and to have a transparent process that could be defended publicly, and a process that was seen as reasonable and fair. So fair decision making and being able to have fairness during a pandemic was seen as very important. Something about having fair and equitable care is really key. So we also had to be able to show responsiveness. So we decided, following that, if we go on to the next slide, Megan, that we would set up a separate decision-making group. And we decided that in that spirit of needing to make it responsive, would meet twice a day. And we had quite a debate about how we were going to staff this, how we were going to manage it. But we actually had an enormous number of senior clinicians and leaders across the trust who were really helpfully offering their time. And we restricted the time allowance to 30 minutes. So it was twice a day for 30 minutes. So you can see straight away, this is quite different for most of us, used to working with colleagues where we're in meetings discussing for quite lengthy periods of time about care. So it was quite a sort of rapid and quick, and the need, I think, at those early weeks was we need staff who come onto a shift at 7 in the morning and are faced with a dilemma to know they haven't got to wait long to talk to people who might be able to support them with difficult decisions. So we also had in place a process for which, if things were worrying, they could be escalated quicker. So we were really trying to be available for people very quickly in a very immediate way. And the aims of the group were we wanted to make sure we were thinking about making the right decisions about prioritising service provision. So that really is thinking about, who should be being transferred, who should be getting access to oxygen. Now, I have to say, we didn't get to that point. Those kind of decisions we weren't faced with, which was such a relief. But that was the aim, that was the thinking in those early days. And balancing individual and wider community health needs and human rights. And then thirdly, workforce decisions. So we set it up twice a day, 30 minutes. Senior staff. So if we could move on to the next slide, we had a lot of discussion about trying to make sure staff were clear when they were coming, because they're only coming for a 25-minute, 30-minute slot, to be quite focused and quite tight about what they needed help with. So we weren't trying to replicate the usual clinical discussions that might be quite long and in depth and think about a full formulation. We really wanted people to get very honed in on what is the particular issue that is troubling either them or the team that they work with, and what was the decision that we were making so that we could have some record and some accountability of our actions. So if we could go on to the final slide. In those early couple of months, we had large numbers of requests for support with decisions about inpatients, which largely focused around risk to themselves or to others, usually associated with either them having suspected COVID or ending up being tested positive. So it wasn't the kind of decisions we expected to get, but it was a very challenging working environment for staff. And as somebody said earlier, that you have to keep in mind that our staff are also coping with the anxiety of COVID and the impact on their own family. So we're not just dealing with a work-based issue, we're dealing with an issue that's affecting everybody to varying degrees. And huge difficulties about staffing in our inpatient environments in the early weeks as well, when we were having a large number of staff who had needed to self-isolate because of contact with potential positive cases and not really any suitable testing. It was quite a challenging time. But then fairly quickly, the numbers really started to reduce. So I think what we'd set up was, it was really nice to know that as an organisation we were there for staff, but we weren't actually being used that often. And we had a very responsive process by where if there was no request, we didn't meet up. So it was a very kind of, we were there if we were needed, but we didn't waste time having meetings where there were no requests. So by about July, we had very few. And then I think what is worth commenting on now is we are beginning to see the increased requests rising again. So I've said November, we're now into December. It's kind of what you would expect with the increased numbers. And I think staff are much more confident about how to manage some of those dilemmas, but we have got an eye on how this pandemic is going to end up impacting on our staff over the next few weeks and certainly after Christmas. And I just thought I'd just make a comment about what I think has been really worked well. So there's something about really important that the organisation and the NHS widely is acknowledging the importance of looking after staff during this time. But what we found in our own organisation has been really impressive. And I think this is not just for the ethical decision-making group, but a number of different work streams many of us have been involved in, is the flexibility of staff. So we've had an enormous shift in terms of how staff have stepped up and have come forward and have offered and have been available. And their responsiveness and flexibility, I know Sam has commented on it before, but it has been remarkable. It has been one of the really positive outcomes of what we've been through together. And I think the support that we were able to give staff was really important too. So we were really trying to endorse what clinical teams were already thinking. We were trying not to be used as a way of criticising or undermining what was already multidisciplinary discussions and decision making. We were trying to support the processes that were already there and hope that we could also be ensuring staff weren't left feeling that things shouldn't have been done in that way. Because I think my sense is that's kind of very much part of the picture, that if you're left with those shouldn'ts, you're going to be it's going to be a more difficult place for you. And then something about the online nature, which of course we're doing the webinar like this, we've got video meetings have now become normal, but in those early weeks, they were very challenging. They weren't straightforward. People didn't have very easy access to Wi-Fi. Often it would drop. People would be in and out of video meetings all the time. But the fact that we were able to do it by video, I think made this accessible. So it made it accessible whether you worked in Hastings or Chichester or Crawley. You didn't have to think about driving for an hour and a half just to get to the place that the senior staff were meeting. So it's been an incredibly useful tool to ensure that actually we can reach out to colleagues who are working all over Sussex Partnership Trust. I'm talking about Sussex because it is largely adult and older adult clients that we were talking about. We mustn't forget we have many colleagues in Hampshire as well. But there's something about the video element of this that is really important and really shows, and I think this comes back to what mental health and learning disability trusts are good at, that multidisciplinary working at its best is amazing, and it can be a fantastic benefit to us all pulling together and trying to think about what we all bring, which I think is probably quite different to those colleagues we have working in acute settings. So I think we have got some advantage that we are already good at working in a multidisciplinary way and supporting each other with some very challenging decisions. And that's all I want to say on that. I hope that's okay. Thank you very much.
Brilliant. Thank you, Sophie. And in some ways, it really kind of nicely rounds things off, because one thing that an ethical decision-making committee can help do is hopefully help prevent moral injury to some degree, at least, in that there's some shared responsibility and kind of discussion. So I think that's a really kind of positive note to kind of end the talks on. There is an opportunity for kind of some questions and kind of comment. I've got one immediate question from Hannah in the Q&A for you, Sophie, which was who is this ethical decision-making committee open to, and where is it advertised? How does Sussex Partnership staff access it?
Oh, that's a really good question, and I'm not sure I'm going to be able to answer it. I'm thinking that you're thinking about how staff who've got a difficult decision.
Yeah, if staff have got a dilemma, what would they need to do, and where?
Sorry, I understand the information's on the intranet. I haven't, because I'm on the panel, haven't checked that. I do know that we've had a large number of people getting in touch, so they must be a way of finding out. I can make sure we've got the link, if you like. Are we going to be circulating something at the end, Nick?
Yeah, so all the slides, and I noticed there was an email address on your slides about where queries might be sent to, but I agree, I expect that there must be something on the intranet. So amongst the materials that are sent through kind of Vicky,
yes, you're right.
What we'll do is we'll make sure that this is in there as well. And this is particularly targeted at Sussex Partnership staff, but we will make sure that that is in there. Thank you.
But can I just add, Nick, just as a quickie, is that just to remember that the ethical decision-making panel is there for some very specific, difficult decisions around COVID care and things that we might not ordinarily be facing. It doesn't replace the usual ward reviews, clinical discussions, team clinical discussions, complex case meetings. So we have had a few examples of staff coming to ethical decision making who thought that that was where you go first. And I think it's not the first place. It's very much after you've been through all the usual mechanisms. So it's definitely there and available, but I think it needs to be thought through. We have lots of difficult and complex ethical decisions to make. This isn't the place for all of them. Does that make sense?
Makes perfect sense. And what I hope is that the kind of the guidance on the intranet will help in that kind of sort of immediate kind of decision making about where to go for what. No, definitely. there's a couple of questions that I've kind of been sort of sent privately. One of the things that somebody's asked is, it's been quite adult focused, and as a trust, well, clearly we cover the kind of the full age range and also people with learning disabilities. And I just wondered if any of the panel had anything they wished to add around kind of other client groups outside of kind of adult in particular. Sorry, Sophie.
I'm sorry to come back again, but I suppose it is largely adult cases that have been presented. But I would say it's not only, and we have had a number of young people, and we have had a number of people with learning disabilities, and we've certainly had quite a number with people with dementia. Yeah. So those populations, it's just that we haven't had large numbers. So all of those populations, we've had a few from each, but it's very much inpatient focused. So it's, if you're thinking about the difficult decision making, we have been thinking about people in Chalk Hill, for instance, rather than more broadly.
Yeah, no, thank you, Sophie. That's really helpful clarification. And just thinking about the concept of moral injury more generally across care groups, Vicky.
Yeah, I was just going to say that's a very good point, because again, it had come from the sort of the veterans side from us originally, thinking about this. But as you mentioned earlier, this is something that we, as a group that came together with this, is, you know, looking at different areas and what, as a trust, what people are wanting to know. So it's something that we can definitely focus on talking about as we start developing other areas of interest. So I will make a note of that as well.
I think part of the thing is for us who are in this room right now, but kind of for others, for those of you who are listening, to kind of to make links with some of us, and for us to reach out as well, because I'm aware that kind of, you know, for example, those people who may be working in kind of safeguarding or child protection, there's kind of literature around moral injury in kind of staff in those areas where, you know, you may wish to provide care in a particular way and that's not possible. You're seeing other people do things that you, you know, wouldn't wish to see. And, you know, there are lots of challenging circumstances for kind of service users, families and our staff kind of across the care group. So I really do want to kind of make sure that we're kind of opening up to all of those areas. The other kind of question that I've been sent kind of personally is actually around, calls back to a comment that Neil made in his talk actually around chaplaincy services. And I just wanted to kind of, again, put to the panel, and I can see your cameras on there as well, Sam, you may have comment on this, which is thinking about kind of Sussex Partnership chaplaincy services, and where would they kind of fit into this kind of overall picture as well? It's not aimed at you, Sam, it's for everybody.
Yeah, I'm really happy to. I thought Neil's point around spirituality was, I think, kind of really, really important one. And Simon Hobbs, who's our lead chaplain and also chair of our spirituality network for the trust, has been quite prominent in this. So he's led a number of things, and in fact, just Sunday just gone, we did something for our trust charity Heads On together, which was all about hope, lighting a candle for hope. And I think there was a lot of real connection to spirituality and the way in which it can support us collectively and individually during this period. So I think it's about it being really plugged in, having a presence. They're available for everybody. And I think, again, in this, I think one of the things that's been really powerful about this session is that sense, and Neil made this point as well, that we're all in this together, whatever our roles, patient, manager, clinician, you know, whatever our roles, we're all in this together, and we might be impacted in slightly different ways, but we are all, I think, open to, you know, suffering from this, and we can equally help each other. So I think Neil used the phrase, if it doesn't kill you, it makes you stronger, which I have to say I shuddered a little bit at, because I used to have a manager years ago who used to say that, and you knew that when you went into their office, it was not going to be a nice experience, and you almost put through that. But equally, and I just go back to that visit I had last night, there was a real sense of, through adversity can come strength and togetherness. and we can all support each other in different ways. And spirituality we need to be really open to, and it needs to be accessible to everybody.
Brilliant, thank you, Sam. I don't know if anyone else wants to add anything further to that. Great, I'm aware of the time. There are no further questions that have come through. It's almost kind of sort of on the dot. I really like kind of the phrase that you used, Sam, from just recently about the lighting the candle for hope. And I think that's hopefully one of the things that we're kind of sort of doing here as part of a process. If your hope was that there wouldn't be feedback forms, I'm afraid you're sadly mistaken. There will be feedback forms, as there are, because we do want to get your feedback. We do want to get your engagement. Those will be kind of you'll sent a link to, and also kind of for the materials. It really just kind of leaves me to kind of round things off, saying thank you very much to kind of all of our kind of presenters, to Neil, who has now left, but also to kind of Anita and Catherine, to Sophie, and to Louise. And thank you very much, kind of Sam and Vicky, kind of for introducing things kind of at the start. And we look forward to continuing the conversation with those of you who are kind of joining us live, but also with those of you who are hopefully looking at this kind of the recording after the event. So thank you very much, and goodbye.